As we all know, quality healthcare is not always a guarantee here in South Africa. Inequalities exist between those who can afford private medical care and those who rely on the public system. Now there's another issue, though, that's being brought to the fore. Race and language can be a huge barrier, especially between patient and doctor, and that's where you don't want any miscommunication at all. But Dr. Angelique Coetzee from Solidarity Doctors Network joining us. Hello to you, Doc. Good to have you on ENCA, as always, because this is not the place where you want to break down in language. You don't want any confusion between patient and doctor, do you?
Yes, good morning, Gareth, and all your listeners out there and viewers. Language is extremely important, but it should not be the only defining criteria for service delivery. I think it is important to understand. I will take myself and my community that I'm serving is a predominantly Afrikaans-speaking community. So it is very interesting if I do get a locum that come and helps me out, and that locum can speak Afrikaans. It doesn't matter what race that locum is. If that locum speaks Afrikaans to my patients, they love that locum. And I would not hear any complaints. So it is important that we understand that language should be a part of the criteria. But you also need to understand the community in which you serve. The cultural dynamics, as well as the language, should be one of the most determining factors of rendering a good service. If you understand the community, if you understand the small nuances and how to address the people that you want to serve, it makes a huge difference. It's not about color. It's about I be able to speak a language and I understand you. I understand where you are coming from. That makes a difference.
Of course it makes a difference, and it's especially tricky in our own country, isn't it, where we have all these various official languages spread around the country, Eastern Cape, Northern Cape, never mind the dialect and the jargon and the slang and knowing the community as well. Because it does come down to the point of, do we need more rural black doctors to be in more rural areas? And as you say, this is not a race issue. If someone, for example, if I was completely fluent in Xhosa or Zulu, and I was a qualified doctor, it would be fine for me to go there. But this is where we start seeing these issues on the ground in the doctors' rooms, don't we? Do we need more black doctors in rural areas?
Well, that's a difficult question as well, because if you are a black doctor, fluent in Xhosa, and you are now expecting to treat patients in another black language, and you cannot speak that language, or you don't understand the culture, you're also going to get in trouble. So if you want to use more black doctors to go out to the rural areas, then you need to identify those doctors. You need to identify the rural areas that you want them to deliver a service in. And then you have to make sure that you are contractually obliging them to make sure that they stay and go back to that community. It would be interesting to look at the stats, because as it currently is, a lot of doctors, or the majority of doctors admitted to study medicine are from the black rural and black communities. And if we then look, how many of them really go back and serve their communities, that will give us the answer whether the current drive would be the correct drive. And, for me, Justin Brown just recently released an article where he said that with a desktop search that he did for international, that in addition to excelling academic doctors, need also to be excellent communicators, empathetic, organized and able to manage stress and to work well in teams. They should be curious, detail-oriented and committed. And this is extremely important. So we need to look at those type of qualities. And then again, if you identify doctors in a deep rural area and you want to send them back, there must be some obligation for them to go back and serve those communities, because that was why you were chosen form to
Obligation,
study
I
medicine.
would agree, Dr. Coetzee. Obligation is one thing contractually as well, but let's not take away. Let's talk about how important doctors are and the amount of studying they've done as well. We need to pay these doctors. We can't expect them to just necessarily go back to work in rural areas when, let's be honest, if you can get yourself a nice, cozy private practice in Sandton or Rosebank or Clifton, money talks as well, doesn't it? Let's be honest, we need to pay people for their expertise, don't we?
Yes, unfortunately, you cannot go to Pick and Pay and tell them, I'm a doctor, I'm serving patients with who can't afford to pay me, therefore you need to give me a bread for free. You cannot do that. You cannot expect that. But this is another problem that we are now sitting with. So if government wants these doctors to go back to the deep rural areas, what are they doing to fix those clinics? What are they doing to make sure that there's enough posts? As it currently is, there is not enough posts. There's not money to pay these doctors. So what are you actually creating here? Are you creating an expectation that you are going to send these doctors back? But then when it comes for time for them to go back, you say, sorry, there's no money, so, you don't have any obligations towards us. We will, your bursary would not be, you don't need to fulfill your bursary because of a lack of funds. So we are back again at the same problems of poor infrastructure, not enough money, and then you want to train more doctors for rural areas. I will not go and work in a rural area where there's not enough electricity, where there's not enough medicine. How can I treat a patient? How can I treat a patient sitting in front of me, expecting that I would do my best for them, but there's nothing? How do I do that? I cannot do that. Ethically, I cannot do that.
Let's go back, just a last question to you, Dr. Coetzee, before I say goodbye. Let's go back to the language issue on this. Where do we begin to try and fix that particular issue? Because infrastructure, you and I could sit here all day. I'll run into Heidi Jockers' show by the time you and I have finished. But away from infrastructure, the language thing, which is what we started talking about, where do we begin on that? Where and who pulls the first trigger to fire that bullet off?
At school. At school level, we need to start to look at your mother tongue, what is important, to train those, to make sure that people, especially in the primary school level, that there's more than one language and that you are being served in your language that you speak at home. I have now seen as well this past 2 years with the COVID and children not going to school, how poor they understand language. Well, if the area where I am practicing, it's a middle class area, if a lot of these children can't even communicate properly with me because of lack of grammar, lack of language, and that's their language that they speak at home with their parents. How are we going to make sure that our children, if they are in matric, wanting to do other courses, that they are fluent in their own language, first of all, and then be able to grasp what they are saying and to understand their own language. I still struggle. I'm Afrikaans, and I've coming from an Afrikaans background, and my English are not the best English, but this is the best that I can do, and I'm trying my best, and I can understand my patients. But I'm afraid that a lot of the youngsters would not be able to understand. They won't even grasp the language that they are supposed to understand.
And it's so important as well for patients who trust doctors with their lives to actually understand their language and their concerns, their health problems in their own language. It's all about that trust, isn't it? So Dr. Angelique Coetzee from Solidarity Doctors Network, I thank you for taking time on a Saturday. I'm sure we'll speak again in the near future.